it's 6 o'clock, right, Kavita? Yeah. Cases. So just get ready with your chat answers and then send it to everybody. So this one is 6-month-old, 6 kilos, pink baby, conclusively pink, asymptomatic since birth. Pediatrician sound, so the preferred for evaluation. On evaluation, O2 is 90%, quiet volume, no retractions, no signs of heart failure. F1 noted. What do you think of? What are the possible diagnoses? Anyone? Okay, mild, yes, mild, yes, but why is the P2 so loud? Pink, again, you should get a soft P2, right? So we are very loud S2. What do you think of loud P2? What here, right? So that would also rule out a PS or an AS. So significant murmur. So you'd not be thinking of stenotic lesion. Even a tetralogy, generally you'd have a 2/6, some systolic ejection murmur. So normally this stage A2, P2 equal, but when you have a loud P2, it still suggests it's a 6-month-old, right? It's a hypertension. Your possible diagnosis at this point would be that there is pulmonary hypertension, right? Into the causes for the pulmonary hypertension. Now I tell you, yes, this patient has pulmonary hypertension. Question: idiopathic pH, but in that case, why is the saturation 90%? What do you think? So idiopathic pulmonary hypertension at this age, they're not generally going to be yet desaturated, right? That you get desaturated much later. So this is 90%, and the diagnosis is pulmonary hypertension. So we do an echo. And here you see this long axis view. This is your LA, LV aorta, and you see on long axis view, the diagnosis was a large VSD with a bidirectional shunt. There's no heart failure. There's no actions, no signs of heart failure, no murmur of extra flow across the pulmonary valve. So how is this a large VSD? So the absence of heart failure and the history of heart failure rule out left to right shunts. To that. Heart failure, can you categorically think there's no VSD? And there is VSD, which is a VSD where you large VSD, but the baby will never have heart failure symptoms. What that entity? Anyone? So typically these, as we know, at 6 weeks, yes, so so it is called non-regression of fetal pulmonary vascular resistance. It's an entity described in Japan, where, as we know, typically in large VSDs, if a baby is born with large VSD, what happens? They've got pulmonary PVR. Then around 4 to 6 weeks, the PVR drops down. Why drop down? Because of physiologic anemia, because the media inside the arterioles is becoming thinned out. So typically they go into heart failure at 6 to 8 weeks of age stage after birth. Now, in situation of a non-regression of fetal pulmonary vascular resistance, for what reason that PVR never drops. In fact, when autopsy and studies have been done, the media in the arterioles remains thick. So there's no regression of that, no thinning out of the arterioles and media in the arterioles. And this is called non-regression of fetal PVR. These babies never have heart failure. So the clue to diagnosis in this baby, right, for a evaluation. Because the pediatric sound, what was that loud sound? The clue. Clue could be that, right? But the clue is also your loud P2 or your loud S2. So yes, the pediatrician had been doing his SAT at every well child check. He could have maybe picked it up because he said, why is the saturation 80-90%? But as you know, most pediatricians don't take a SAT and babies are crying and they're not sure about the SAT. So listening for a loud second heart sound, so a loud P2 is one clue. Now manage these babies. What different options for such a baby? Would you close? Would you not close the VSD? Like they're almost like a VSD Eisenmenger, right? Except that they never had a period of heart failure. This month old, what would you do? Anyone? Medicine for PH. So like what? Like what medicine for PH? What are the things you do medically for PH? So Silantrin, right? That's a reasonable option. Kids like this may land up getting capped, but in general, you will close it. Now, close it, then of course it's definitely going to become Eisenmenger. So you have to do VSD closure. Parents, you may have to go home on sildenafil bozantin. What's the other thing you may need in the post-operative ICU in a case like this? Nitric oxide. So this kind of case would be a very high risk surgical closure. It's very different from a large VSD with heart failure symptoms, not gaining weight, where the pulmonary vascular resistance is low and the PV is low, they have still pH, but they present with signs of overcirculation. When the P is high and the PVR is high, they present with signs of overcirculation, and those babies are very high risk, but it has to be done. High risk surgical closure with post-op nitric oxide and sildenafil. Many times with these babies, when you go actually to close the VSD, biopsy can also be done because it helps to prognosticate it. What are the stages? Like for instance, if you see Heath Edwards stage 4 changes, he's not going to do very well. If you see, stage 1 or 2, you can hope that there will be regression, thinning out of the pulmonary media over time. Okay, but important for everyone to know, large VSDs with non-regression of fetal PVR. Okay. Okay. 2. 3-year-old with history of sweating with feet, poor weight gain. On pink, O2 sat is 100%, has retractions, active precordium, loud heart sound, 2 by systolic ejection murmur at the upper left sternal border, MDM at the apex. What do you think? Possible? What are you thinking when you see this? Sweating with feet, poor weight gain. So thinking of a left to right shunt, right? A large, it could be some left to right post tricuspid shunt, right? Because you've got heart failure, you have systolic ejection murmur, which means increased blood flow, you have MDM at the apex. So they're all suggestive of a post shunt. Okay. Do an echo. Baby for echo. Echo comes back. IVS is intact. No PDA. Structure normal heart. LV dilated. What missed? So you think shunt. So AP, anything else? One. So you've got heart failure and left heart dilation. An AP window was. Anything else which can do that? Heart failure, left heart dilation. But they would have picked that up on echo. So they have said structurally normal heart. Right? And it won't necessarily give you all the signs of a left to right shunt. A to LA shunt. Pulmonary to LA shunt. What is that like? What does a PA to LA shunt mean? Vein Galen, you mean? Galen, Galen could be heart failure. You usually get all 4 chambers get dilated, right? You get even right heart dilation. Because coming back from the brain first into RA, then into RV, and then out. So overall, here's specifically left atrium, left ventricle. Anything? Okay, coronary cameral fistula to the LA is one. Anything else? Think of. You heart failure, left heart, no VSD, no PDA. Anything like an AP window. AV machines on the lung, they'll typically be blue. Emissions because if you have AV malformations of the lung, they'll be blue because you don't get oxygenated. AV formations of the B, okay, you could think of that because they've got, but generally get overall kind of cardiac dilation, not just to right, just LALV. Anything else? One more thing is like AP window, which will be, remember there's also loud P2 here, right? So a lot is like vein of Galen, AV malformations, you have pulmonary hypertension, hemituncus. You must not forget hemituncus. So heart failure, loud P2, and left patient. And you're seeing echo report that's saying IVS intact, no PDA. These two things that you have to rule out: AP window, origin of the pulmonary artery from the aorta or a hemituncus. There's no pulmonary hypertension. Okay, so other things that cause heart failure, maybe severe anemia, it could be, system malformations and so on. But when it is loud, you're thinking pulmonary hypertension. So these lesions you've got to rule out. So what has been the clue on physical exam for these two lesions? Physical exam for an AP window. Pulses. What is one exam for a trunk? Bounding pulse. So these are like a PDA, except there's no PDA. So that is again the importance of putting your finger on the pulse in every patient you see. So heart failure, bounding, loud heart sound, AP window, and hemituncus. So on this, we'll move to the next one. PP pulse pressure, yes. Okay, three. Asymptomatic child noted to have a murmur. On is pink, normal femorals, no radiofemoral delay, normal pressure, quiet cardium, there's a carotid thrill, there's no ejection click. 6. Non-vibratory systolic ejection murmur at the upper external border. What are some diagnoses? Big fell or mild PS could be okay. So, which, when you're saying mild PS, which kind of PS would this be? So, murmur, but I've said it's not vibratory, right? Because stilled murmur would typically have a vibratory tone to it. This is non-vibratory. So PS, go over PS. If you think this is PS, what kind of PS could this be? Okay, possibly, but we haven't commented on the split second sound. Say PS, what kind of PS? It would be a PS, right? What do you mean by non-valvar PS? What kind of PS? So give an example. Okay, infundibular, what else? Any valve this could be? So supra subvalvar. Any PS that this could be? Like pulmonary valve, because there is no click. Now, let us say I tell you this is not PS. This is not PS. Is the other stenosis this could be? Say I tell subvalvular stenosis, there is no gastric valve. On aortic side, you can think of No, it's not ejection murmur, right? So it's got to be some operative. So aortic membrane. What's aortic membrane? There's carotid thrill. If there's no carotid thrill, we're kind of ruling out aortic stenosis, right? There's no ejection click. So there's not valvar AS, but a subvalvar AS, like a subaortic membrane. Or a supra, but more commonly sub. Will not carotid thrill and it will give you a murmur. So these are the things to look at. So non-respiratory would have ruled out flow murmur. Sub-AS, an example, subaortic membranes would you could think of with AS, and PS you think of if it's P valvar or a dysplastic pulmonary valve. And I will tell you, when I was a fellow, I had a case like this, and I listened. I thought, oh, flow murmur. So my said, just get an echo. So I said, it's a flow murmur. And he's like, just get an echo and make sure there's no subaortic membrane. And with the subaortic membrane. So I learned, I never call now anyone a flow murmur. Just done one echo to make sure that there's no subaortic membrane. Those are the kind of things you don't want to miss. And then echo as well, you look specifically for a sound. Because you know systolic ejection murmur, no carotid thrill, there's no ejection click. So you've got to be thinking of these things when you're doing your echo. No click and it's pulmonary stenosis, it should tell you that, hey, is this dysplastic? Or is there narrowing and so on. This M mode of the mitral valve, any diagnosis? MVP. Why are you saying dynamic obstruction? Like what? What dynamic obstruction? So see, what is SAM? Full form. What's the full AM? You're saying anterior motion. Okay. So there's now when we say MVP, we've got to see it in diastole. Sorry. MV, we've got to see it in when the ventricle, when the valve is closed, right? Because when you're going to see the mitral valve prolapse, and it should be, you should see it in 2 views, at least 2 millimeters. This is not that easy on just the 2D, but let's look at the M mode, right? So if you see here in M mode, you look, let me point this out for you guys. This is right. So that's the ventricle, right? Wall of the LV. What is it? It's squeezing. So now this is really. Now in the right, what the mitral valve should be? So this valve here, right? Your mitral should be closed, but the mitral valve up here. So as you can see here, how the valve is. Actually, this is systolic frame. It is motion towards the interventricular septum. So this systolic anterior motion of the mitral valve. Okay, do you see this? Which condition? Everyone mute yourself. Yeah. Kavita just. Yeah. So yes. So it's commonly seen in HCM, which is hypertrophic cardiomyopathy. It doesn't necessarily have to be seen in HOCM. It just can be seen even if you have HCM. Now it's been described in hypertension, diabetes, after valve repairs, and so on. Now, anyone know grades of anterior motion of the mitral valve? We'll just go over this because grade 1 You don't need contact between the mitral leaflet and the ventricular septum. There's 10-meter gap. Gray, no contact, but it comes closer. 10-millimeter gap. Gray, the mitral leaflet actually touches the septum, only 25% of systole. Gray, mitral leaflet touches the septum throughout. More than throughout, but more than 30% of systole. These are the gray of systolic motion. We said we see systolic anterior motion in HCM. So what is the definition of HCM? What wall thickness do HCM? What is, if you see, more than what? 15 millimeters. Any one thickness to the normal, okay? Any exception, can you call it HCM when it's 12 millimeters? Are there exceptions to this? Non-athletes. Athletes. It's a family history. Basically, if it's a family history of HCM, right? Say one person index, somebody in the family has HCM, and you are following up the other family members. Start seeing some hypertrophy. And if even less than 15 millimeters, you can then suspect that this is HCM based on the family history. Basically, definition of HCM is hypertrophy, non-dilated left ventricle. So a cardiac or systemic disease capable of producing hypertrophy. Usual cutoff is 15 mm. Now, to differentiate an athlete's heart. We know that an athlete's heart also becomes thick. Give some tips to do these two on how do you differentiate them on echo? Well, echo. So tension. So which one is dilated? In which one? The dimension means normal HCM, dilated athletes. ACM, low concentric in athletes. LV 35 mm in athletes. That means dilated LVs basically. Anything else? Dilated LVs, concentric LVH. Anything else? History. Your family history of HCM goes with HCM. Reverse stopping exercise goes with athlete's heart. Anterior motion would go with athlete's heart. That's right. So family history and then the dilation. It's HCM, dilated athletes, hypertrophy. The unusual location of it favors HCM. Systolic motion favors HCM. And LVH more than 25 millimeters. So we said more than 15 mm, but it could be athlete's heart. If it's more than 25 millimeters, it goes more in favor of HCM. Generally, athlete's heart don't become that thick. A deconditioning period where they don't exercise and the wall thickness comes down, that favors heart. Okay? Yeah? Now, AM is a mutation in which group of genes? And I don't know names, but what type of gene? Sarcomere. Well, it's actually sarcomere, the protein, right? So it's an autosomal dominant mutation in genes that encode for the sarcomere protein. All these different genes, let me mute someone. Yeah, we can mute everyone. I think this one. So genes, myosin binding protein, but these are all parts of the sarcomere of your sarcomeric protein. 50%. Now, what are symptoms of HCM? What is the commonest symptom of ACM? How do they come to life? Commonest symptom of symptom, exertion, syncope, yes. Angina, syncope, dyspnea and exertion. Any other symptom? Sometimes also have a thromboembolism, which is the commonest of all symptoms. Commonest, you would think, is symptom. So actually, the commonest symptom is dyspnea. We watch angina or sudden cardiac death or syncope. Those are, sudden cardiac death is obviously most devastating. If someone has a VTAC and sudden near death, of same syncope, angina, palpitations, but most common symptoms that actually do they get dyspneic and HCM. What is LD? Left diastolic dysfunction. Well, yes. So because the left becomes thick, it doesn't relax, it doesn't let the its is reduced, so the air cannot empty into the LV, and so you get back pressure on the lungs. So the commonest symptom is dyspnea, which is why when you get someone with kind of unexplained dyspnea, it's worth doing an echo. You X-ray obviously to rule out respiratory things. It's worth doing one echo to make sure you don't have things like this, mitral vein or pulmonary vein obstruction, or sometimes you unearth a HCM. Now, HCM, sometimes we do make them exercise, and if you see an abnormal blood pressure response, it's actually a high risk. They're at high risk for sudden cardiac death. What abnormal BP response? What would be your normal BP response to exercise? What is the normal? Saying is 20 mm fall. So, a fall 20 mm, or it doesn't increase by at least 20 mm. Both these are considered abnormal blood pressure responses. They are actually one of the factors associated with sudden cardiac death. Exercise, you should increase your blood pressure by at least 20-30. Why? Because you increase your overall cardiac output, so your BP does go up. You should never drop during exercise. And why drop during exercise? More dynamic LVOT obstruction. So a drop in pressure or no rise beyond 20 mm are both a bit icy and one of the factors associated with sudden cardiac death. Treatment options. Can you mention some treatment options in HCM? First, beta blockers, calcium channel, verapamil. Now let's told you patient has HCM, asymptomatic. Would you do anything? Would you put on Would you put on? You just follow. They've never had any symptoms, right? So you would put them on prophylactic medication if they were high risk. So who are the patients who are high risk? Who are hypertrophic cardiomyopathy who are high risk? And after 15% means? What does that mean? Thickness you mean? No. What's L short forms? I'm lost. What LGE? Gadolinium scarring. Okay. So you're saying okay, myocardium is very abnormal. Okay, simpler things. Clinically, how will you evaluate who's at high risk? So you have a family history of what? Family sudden death. So family sudden death. What else? What are the other high risk features? Okay, Apple BP response. What else? What if the syncope? That is suggestive of the same, right? That's an abnormal. So syncope, if they have had a near death, right? So these, and if you have LV thickness more than 30 mm, these are very high risk. So before we go to high risk, let's just go to this. How do you read? And I've just put the reference up here for you all. This is December 2011. This is the guidelines on hypertrophic cardiomyopathy treatment. And so you see, it's well worth going through this because every patient needs treatment. It's not that you diagnose HCM and you put them on something, right? So this whole, basically, if there's no obstruction, right, and symptoms, heart failure symptoms, no angina, you can just do follow-up. But the symptoms, heart failure or angina, then you're with them with beta blockade or verapamil and so on. Even, so let me put this pen here. So here, no obstruction, no, then do follow up. If they have symptoms, right, then do, depending on the left ventricle ejection fraction and so on. But let's say they have symptoms, no obstruction, EF, okay, you can use beta blockade, verapamil. If they have obstruction, which is here, right, then look, if they've got failure symptoms and so on, if they don't think, just do follow up. If they have failure symptoms, again, you're back to beta blockers, verapamil. If they keep symptoms in spite of medications, you assess them. Can you do myomectomy? Can you do alcohol ablation? Which is one of the options to remove that obstruction. So consider them for ICD or a pacing, the deep pacing. If they've had any syncope for ICD. So basically, if there are no symptoms and they are low, you can follow them. If they have symptoms, or alcohol ablation. If they are at risk, you've got to think of intravenous defibrillators, ICD. Now, who are at high risk? Right? So the highest ones are if they have a family history of sudden death, if they have cardiac arrest, they become very high risk. If they have unexplained syncope, which basically is also like a VTAC, and this is more than 30 millimeters. So patients, you on this. Now, when someone is diagnosed with HCM, how frequently should you screen their first degree relatives? So say you have a kid, right, or a mother diagnosed with HCM and has 2 years old, and the kid is normal. Should you keep screening the kid? Should you screen? So mother, you have to screen the kid. How frequently? The answer is annually, till 18. Less than, if they're young kids, right, less than 12 years, you have to keep screening. Like when they're 2 or 3 or 4, you could just kind of say every 5 years. But once they cross 12 to 18, every year, till they hit 18 years, grown 18 to 21 years, then 5 years. So to make it easier for yourself, rather than this less than 12, more than 12, just say every year till they become adults, every 5 years. So if at 18 or 19, they don't have evidence of HCM, it would be quite unusual for them to develop HCM. So generally, if you're got a negative echo at 2-year-old, 3-year-old, and it's negative 18 years, your kid is probably safe. But every year until adulthood, and then every 5 years. That is the screening policy. Okay. last 7-day-old with this X-ray, what's your differential? So could be okay. We do an echo. Okay, that is 20%. Diagnosis. Normal heart, EF20. So if your ejection fraction is low, it goes with DCM. So if you see it like this, it could be Epstein, severe, or it could be dilated cardiomyopathy. And then echo, if the function is poor, that goes with dilated cardiomyopathy. So now, okay, this is 7-day-old, right? What are some of the blood tests you want to do? His ejection is 20%. Heart is not pumping. What do you want to look for? What are the things you want to rule out? Fraction, okay, that you look on echo. You'll do a metabolic workup. So metabolic workup, what would be like lactic acid, ammonia, right? Looking for acidemia. Because hypocalcemia and vitamin D deficiency can also cause this. Anything else? So you do calcium, you do metabolic workup. What else? Dilated calcium. What blood work do you want? You go right, thyroid, okay. What else? What's your list? Severe, can it cause DCM? CP can be, why? If you're thinking of what in what case you look at CPKNB? CPKNB thinking of like a myocarditis. We did in a 7-day-old, but okay. POM won't give you ejection fraction low, right? It will give you more a percentage. Very unusual to see it in a 7. You won't have poor function so early. So what work you're going to do? So right? Make sure vaccines okay. Magnesium. Because sometimes uremia and all can depress function, so BU and creatinine. Sometimes glycemia can depress function, so glucose. Severe anemia can cause this, for hemoglobin. And then metabolic workup includes carnitine levels. So leukemia, lactic acid, and whole metabolic screen. Okay, what are the causes of dyspnea in infants? When we stated cardiomyopathy in an infant, it's generally some cause. Okay, it could be alpha, right? So alpha, it's not really a DCM then. It's a structural lesion. It's a cause of heart function, right? So when we say DCM, we mean that there's no structural etiology, but heart function is so, right? What are all the causes you think of in an infant? So same thing, viral, okay, viral, idiopathic, congestive means what? From what? What about cardiomyopathy? Alpha and newborn unlikely due to alpha, see, the minute your pulmonary resistance drops, right? Actually, with the first breath, it doesn't manifest in a fetus because pulmonary artery pressures are high. But it can manifest at 2 or 3 or 4 days. It may not. But as the pulmonary resistance drops and the PA is more, it can manifest. So, dilated cardiomyopathy in an infant, you've got to rule out alpha. The minute alpha is not DCM, 1 to 2 months, because that is when your pulmonary resistance is at the lowest. So that's when your steel is at the maximum. The same reason BS manifested 4 to 6 weeks, also manifests around that time, 1 to 2 months. Say again, that means you've ruled out alpha, you've ruled out what other structural causes of LV ejection fraction being low. One is alpha, what critical aortic stenosis, severe coarctation, all things can present with low ejection fraction. So DCM, that means we have assumed we are ruled out severe critical AF, NGOTO, severe coarctation, and these have all been ruled out. So looking at other causes of poor function, more really is myocarditis. Now, commonest causes of myocarditis, as you said, viral, adenococcus, CB, etc. Yes. Causes of DCM that you should be aware of: inhibition of DCM, tachycardia-induced DCM, anemia can cause DCM, deficiencies in of metabolism, like mitochondrial disorders, vitamin D deficiencies, but in cases no causes identified. This is kind of the whole workup. So that you would do an ECG. Make sure that's why you do blood work. Rule these out. How do you diagnosis of DCM? On echo, what tells DCM? Okay, we rule out structural. We rule out past, critical AS, severe coarctation. What does echo say? No, echo, it is not DCM. How can I say it's not DCM? Diagnosis of dilated cardiomyopathy. Anyone? Same baby has ejection fraction of 70%. DCM? Every dysfunction is a sign. Marked dilation of the LV with dysfunction. Then say this is DCM. So I make this point because we get referrals from pediatricians saying, could this looking big on X-ray, can it be DCM? So you do the echo and you say normal function. Then they do and say normal, but can it be DCM? Right? And the fact, no, it cannot be DCM. So one normal function, or it can't be DCM, it's not DCM. So markation of LV with function, give an echo diagnosis of DCM. Then you have other things like mitral regurgitation. You may have, if it is viral myocarditis, maybe you have effusion, maybe you have thinned out walls, if it's stools or other kinds of things. But the vital thing is that EF should be reduced. Now, put here the actual number of EF less than 50%. So, what is severe LV dysfunction? How much percentage? Severe than what? Actually, then 30. Is it less than 30? What is moderate dysfunction? Dysfunction. 30 to 4. 30 mild dysfunction. To 54, right? So you see here, LVEF less than 50. That means you can have DCM where there is not severe LV dysfunction. So the DCM is dilation of LV, global hypokinesia, and EF should be less than 50%. And this is, because sometimes you'll get kids the EF like 48%, 50%, mild dysfunction. One B, that can be a form of, that is a form of DCM, except it's mild LV dysfunction. Echo diagnosis is not LV dysfunction. Echo diagnosis is LV dysfunction. It can be less than 30%, can be moderate, 30 to 40%, maybe it's mild dysfunction. So dysfunction has to be there to call it dilated cardiomyopathy. Okay, at this point, go again, the severe, moderate, and mild dysfunction. 30, 34, 44. Above 55% is normal. These dysfunction, your management changes. What change? Let's say I tell you patient has severe LV dysfunction. What extra treatment will you give them? Normal treatment. You may choose aspirin, right? You may anticoagulant when they have severe lead dysfunction, which you may not do if you will do if they have mild dysfunction. So, the neonate, what's the treatment you're going to do in the acute phase? This baby comes poor functioning, dobutamine, carnitine, very gently, very low dose diuretic, because they're all quite labile. What else? So you said dobutamine, carnitine, okay. You check this for metabolic workup, then you give carnitine. Make you correct calcium and so on. Inotropes you could use. So maybe ventilator. You can consider one. Any on IVG? Thinking maybe showing that IVIG quite helps, but there are not many studies really in neonates for this. So if you don't give also, it's okay. It's sort of controversial. So, management, oxygen, right? Remember oxygen, ventilate if needed, give them adequate calories. In inotropy, you want to give inotropy plus afterload reduction. So, dopamine is a good choice. Low dopamine, milrinone. These are contractility with afterload reduction. So, they help the heart as well as reduce the afterload. And you use levosimendan. Anyone? Mechanism of action? The new wasn't there when I was a fellow. Mechanism of levosimendan. It's a sensitizer, yes. So calcium channel is a sensitizing agent. It induces cardiac contractility. It also opens your vascular potassium channels and leads to vasodilation. So it's a good example of inotropy with afterload reduction. Low diuresis can be used. Low dose digoxin, not normal dose. If you're going to use digoxin, why low dose? Because they do have, because they're in heart failure, low output, renal issues, so they may not exceed their digoxin, and then you may have toxicity. Plus the myocardium, especially if it's viral, can be sensitive to digoxin. So if you're going to use it, you use it in less than half the dose. Never give full dose of digoxin in anyone, or digoxin in someone who you're suspecting myocarditis. It's okay. Like if it's a metabolic cause, you don't know that when you're first treating them. You're kind of going all guns blazing with your treatment. If severe function, you're going to put on anticoagulation because otherwise they can get clot, which can embolize. Should treat veins if they're there. And IIG steroids, which has unclear utility in neonates. Long also ACE inhibitors and some receptor blockers, beta blockers are not yet routine in newborn infants. And this is view of 2017. I put the reference here if any of you want to read it. It's on new dilated cardiomyopathy. The things are a little different. The way you get comes in leaking myocarditis typically, like 10-year-old comes. And you would consider IgG or steroids because it helps in most cases, especially giant cell myocarditis and so on. But these utility is quite unclear. So you would really give oxygen, support respiration, inotropy with afterload reduction, low diuresis. If severe dysfunction, you may want to add aspirin and so on. I think I shall end with that. And on Thursday morning,